Hi, today we're going to talk about care management of the asthma patient. I'm Ann Batchelor. I'm a nurse and a certified asthma educator, and I've had experience working with both the pediatric and the adult population in inpatient and outpatient settings. So today we're going to talk about some of the new guidelines that were put in place in 2007. We call this the EPR, or the Expert Panel Report, and these guidelines were for primarily clinicians and educators, and they focused on um, a couple of different areas. We want to make sure that we're looking specifically at severity control and responsiveness in terms of treatment. So this was the focus of the expert panel report. They also focused a lot on education guidelines and self-management of asthma care, which we'll talk about throughout the presentation. So in terms of asthma severity, the expert panel report recommends or declassified asthma in two different ways, and this is definitely a change from the previous expert panel report. So we basically now have two categories of asthma. We have intermittent asthma and we have persistent asthma. Within persistent asthma, we're going to stage people as either mild, moderate, and severe. And if you go to the website that I have listed at the bottom here, you can look specifically at the guidelines. And so these guidelines will basically, you'll look at the symptoms of the patient, and you'll look at the patient presentation at the time and the meds that they're taking and things like that, and you'll sort of fit them into categories, and you'll be able to come up with a diagnosis, whether it's intermittent or persistent, and then under persistent, whether it's mild, moderate, or severe. And this is really going to help you because the guidelines that are listed will give you some recommendations in terms of how to treat that patient. So whether or not you're putting them on a steroid inhaler, for instance. So intermittent asthma is basically sort of episodic asthma. Patients don't have symptoms more than once or twice a week. Their asthma is in pretty good control. Persistent asthma is somebody who's having symptoms more than twice a week, who's reaching for that albuterol inhaler quite a bit. And those are patients that are going to need to be put on a control or medication, so a medication they take every day. And that's sort of the difference. So intermittent asthma, they are just going to use their albuterol for infrequent symptoms, less than twice a week, and persistent asthma means that they are using their albuterol more than twice a week. There are other specifics around that, but that's sort of the nuts and bolts of the difference between intermittent and persistent. So looking deeper into the guidelines, some of the key messages here, they talk about inhaled corticosteroids. So one of the recommendations is to be sure that all of your patients with persistent asthma have some sort of a controller, and usually that's going to be an inhaled corticosteroid. Flovent is usually one that we use for adults, and Flovent can also be used for children. And with younger children, you'll often see Pulmicort in a nebulizer used. And so, again, as a nurse, as a care manager, you're going to be sure that your patients with persistent asthma are on some sort of controller medicine. An asthma action plan is number two. The recommendation is that every single patient with asthma have an asthma action plan. Primarily, we used asthma action plans for young children in the pediatric population, but we should be using them with all patients with asthma. We'll talk more specifically about the components of the asthma action plan in a little while. Asthma severity. So we are staging, or we are diagnosing asthma severity at every single visit. So whether or not the patient has persistent asthma or intermittent asthma, and whether that persistent asthma is mild, moderate, or severe, we are using that as a tool to guide our medical management of that patient at every single visit. And so this is something we want to think of as fluid. So the person may sort of be intermittent at one point, and then maybe they fall into the persistent category, and then hopefully they go back into intermittent. And so we're using this at every visit. Asthma control. There are lots of tools used to assess asthma control, which is number 4. But there should be some sort of diagnostic tool used at every visit, again, to assess the control so that we know how to stage their severity. The asthma control test is a really nice one that's often used. It's a quick tool that you can use. You can interview the patient, or the patient can fill it out themselves. You can use it with the parents for the pediatric patient. Follow-up visits. So we want our patients to be followed up not just when they're sick, but when they're well. We know that education always is more effective when a patient is doing well. When they come for their follow-up, they should be instructed to bring all of their medications with them. So that's number 5. Number 6, allergen and irritant exposure control. So we are really focusing here on triggers and recognizing that asthma is not only managed through medical interventions, but also through lots and lots of environmental changes and interventions. In terms of what's happening with an asthma patient, we're not going to go too much into the pathophysiology as this is just a 30 or 40-minute presentation. But here you can see the normal bronchial tube. So the normal bronchial tube is very open. You can see the bands around the airway, which are very lucid, very loose. They're not tight. They're not contracted, and you can see the airway is very open. With the asthma bronchial tube in the next picture, you can see lots of changes going on here. So the bands around the airway are actually constricted and tightening, which narrows the airway. You can see that the inflammation is really filling up lots of the membranes of the airway, and then lots of mucus is coming in as well. This is a great picture to show your asthma patients so that they understand the underlying disease process of asthma, and that it's really the inflammation and this mucus that we are trying to get under control. And the patient should understand that albuterol really helps with the constriction, so those muscle bands can be loosened up through the albuterol use, but the inflammation and that mucus is not going to be touched by the albuterol. So the patient is going to need a controller such as an inhaled corticosteroid in order to help control the inflammation. And if they understand that, they're much more likely to take their controller medications at home. So as we said before, understanding asthma, it's an interplay of genetics and environment. So there's lots of things going on here which make people susceptible to asthma. We can't control genetics, but we can certainly control the environment, so we can do lots of things to help with trigger control and trigger management. Key concept, chronic susceptibility to airway narrowing is in response to triggers in the environment. Again, we just talked about that, so reducing triggers. You want to find out if possible what the patient is allergic to. If it's dust mites, we can control that with some environmental interventions such as using mattress covers on their beds. If it's a child, we want to make sure that they're staying away from stuffed animals, or those stuffed animals are being cleaned. So those are just a couple of examples. The bronchial tube narrowing that we see in asthma is reversible, which is a great thing to let our patients know. The underlying inflammation is always present, although we are trying our best to keep it as low as possible with the use of the controller medications. And it's a chronic disease characterized by episodic symptoms. So the patient may experience just some episodic symptoms, or they may have daily symptoms. But if they have episodic symptoms, it's really important for them to know that they're still using their controllers even when they're not having symptoms. I talk to the patients and I use the analogy about diabetes. So patients are still taking their diabetic medications even when they're feeling well. And this is similar to asthma. So we want our patients to continue taking their controller medicines even when they're feeling really well in order to prevent symptoms. And of course, the focus is on control. So we're not going to cure their asthma, but we're going to control it. And most patients can attain excellent control where they're not having symptoms daily by any means. A lot of our patients present with really complicated picture in terms of their symptoms and their clinical history, and it might be hard for us to determine what's going on in terms of whether it's asthma or COPD. The best way, if we're concerned about diagnosis of asthma, the most useful, well, the only diagnostic tool that's out there are pulmonary function tests. So, if the clinician is unsure, is this asthma, is this something else, a PFT test can be set up for the patient, which can be done in an outpatient lab or pulmonology lab. And that will let us know whether this is asthma or something else going on. But here are some clinical features that show you the difference between asthma and COPD. So asthma is often brought on in childhood, although we do see lots of adult onset asthma. Asthma is often related to allergies, whereas COPD is not. Asthma is not due to cigarette smoking, but with COPD it is. If you give a patient a bronchodilator in the office, like an albuterol nebulizer, and the patient has a large improvement, that's kind of it's not necessarily a diagnostic test, but if we know they improve, then we are leaning more towards asthma. With COPD, you give the patient an albuterol neb and they won't improve. And with asthma, we don't usually see a progressive decline in lung function unless the patient is very severe. But with COPD, we do, especially with continued cigarette use. The thing that really can complicate this diagnosis is for the asthma patient who smokes and who's been smoking for a really long time, who probably has a combination of both illnesses. And that's when medical management can become very complex. So we're really concerned, obviously, about poorly controlled asthma because we know that it leads to an increased use in the healthcare system in general, as well as a poor quality of life. So poorly controlled asthma leads to increased visits to the ER or the clinic, hospitalizations, daily limitation of activities, lost work days or school days, lower quality of life, and can lead to death. We know there are risk factors for death for our patients, and these patients should obviously all be on your high-risk registry. So some risk factors might be past history of sudden severe exacerbations, prior intubation and mechanical ventilations for asthma. So when your asthma patient comes in, you're always asking about whether or not they've ever been intubated and whether or not they've been in the ICU. So any prior admission for asthma to an intensive care unit or any prior intubation is an automatic high-risk registry patient. So we know that they're at risk for a very severe exacerbation and maybe even death. 2 or more hospitalizations for asthma in the past year. So again, we're asking, have you been hospitalized for asthma? How many times have you been hospitalized? How many times have you gone to the emergency room? 3 or more emergency visits will increase the risk for death. Hospitalization or emergency care visit for asthma within the past month. Use of more than 2 canisters per month of your beta-2 agonist, so your albuterol. When a patient calls for a refill and you look back and you see that they have just refilled that albuterol, we want to have a conversation with that patient. We want to find out what's going on with their asthma. We want them to come in immediately. Patients will often get upset that we're not refilling their albuterol right away for them, which we will refill them in most cases, but we want to make sure that we're not just refilling albuterol without making sure that their asthma is being well controlled with a controller medicine. That's the real important point that patients sometimes don't understand because they haven't been educated about it. So as much as possible, you want to get that patient in the door and really make sure that they're taking their controller medicine. What I'll often do is call the pharmacy and find out when has that patient last picked up their Flovent or last picked up their controller medicine, and that will give you the answer as to what's going on with the patient most of the time. This slide is continued. So in terms of near fatal asthma, we're also concerned about patients who have current use or recent withdrawal from systemic corticosteroids. So they've recently used their prednisone, and they've just come off their prednisone, so they're also at risk for more severe asthma. Poor perception of dyspnea. So patients who live with asthma, with really poorly controlled asthma, who have shortness of breath all the time, often have very poor perception of when they're getting worse. So these patients are at very high risk. Presence of other comorbidities such as cardiovascular disease, COPD, serious psychological problems or psychiatric disease, low socioeconomic status, urban inner city residents, illicit drug use, and sensitivity to alternaria, which is a fungi. So the goals of asthma care, we want to obviously prevent chronic and troublesome symptoms. We want to prevent coughing or breathlessness in the daytime, in the nighttime, after exertion. So we want patients basically to sleep through the night, which many of our asthma patients never sleep through the night because they're up coughing and they're up with shortness of breath and they're up taking their inhalers. We want to have patients use their albuterol less than 2 days a week. So in other words, we want them to have not have any problems with shortness of breath or coughing on exertion. We don't want them reaching for that albuterol. I mean, of course, we want them to use the albuterol for having symptoms, but we want their asthma to be in such good control that they're not having symptoms and they're not having to reach for the albuterol. We want them to maintain near normal pulmonary function. So we want them to function as if they don't have asthma as much as possible. We want them to maintain normal activity levels, including exercise and other physical activity. We want them to go to school. We want them to go to work. Again, lots of patients are used to living with really uncontrolled asthma. They will often limit themselves in terms of activity. They miss a lot of school and a lot of work. And for most patients, we can do much better than this. We also want to meet patients' and families' expectations of and satisfaction with asthma care. So asthma self-management, again, we want to identify and minimize the contact with your asthma triggers. So we're focusing on having the patient really begin to understand what's making their asthma worse. Some things you can do to help them. There's there's several excellent healthy homes type manuals that you can go through with the patient. You can get some at the Boston Public Health Commission. They will give out those for free, and they can sort of go through room by room in their house and identify some of those triggers. They come into contact with cockroaches, with mice, with dust mites, with cleaning products, all sorts of environmental, pollens, things like that. We want to understand and take asthma medications as prescribed. So we want the patients to be able to tell us, what are the asthma medications that they take, how do they use them, when are they going to use them. We want them to show us how to do that. We want them to be able to recognize the early signs that their asthma is getting worse. So we want them to be able to verbalize to us, yes, I know when to come to the emergency room. Yes, I know when to come come to the clinic. I know when to call my doctor. So again, concrete signs that they can verbalize to you when their asthma is worse. And then what are they going to do when it's getting worse? Do they know when they should come to the clinic? Do they understand that, if they're taking their albuterol more than every 4 hours, they should take some steps to get some care? How are they going to determine whether or not they should call an ambulance or whether they should just walk into the clinic? These are all things that the nurse is helping them with, and the patient hopefully is developing a plan in conjunction with the clinician and the nurse and family members to help them to be able to live as healthy and symptom-free life as possible. So an asthma action plan, we talked about this earlier. If you Google the Mass Clearinghouse, it will take you to a site where you can order asthma action plans for the clinic. Every patient should have an asthma action plan. We need to work with clinicians to make sure this is done. In the Boston Public Schools, every child needs an asthma action plan to get into school. So we're very used to doing this for children, but we're not so great at doing it for adults. So the asthma action plan, most of them are set up as a traffic light system. So we have sort of the green zone when the patient is doing really well. Here's what we do. And in that green zone, maybe the clinician will write that the patient just takes their albuterol as needed for shortness of breath, coughing, wheezing, etc. The yellow zone, okay, so here the patient is having more trouble. They're having symptoms. This is what they're going to do in this case. And then red is, the patient has taken their medication, the medication's not working, or they're taking it every couple of hours. And so here's the plan in this red zone. So it's very specific for each patient, and it's just a plan of care to help the patient know what to do in each circumstance. So like I said, it's a written plan, it's individualized, and it's in triplicate, so copies can be given to the school or caregivers. The goal is to help a patient and their family control asthma and know what to do if their asthma worsens. It is based on asthma signs and symptoms and sometimes on peak flow readings, although most patients aren't doing peak flows at home. Most of these are going to be symptom-based. It's going to give them specific information on asthma medication schedules and what to do in different situations, and it will help them to understand when to go to the clinic or when to go to the emergency room. So in terms of patient teaching, like any disease, patients need to be taught about asthma. Patients, when they're diagnosed with diabetes, often get hooked up with a diabetic educator and a nutritionist, and lots of things fall into place very quickly for these patients to help them take care of themselves and to reach optimal health. With asthma care, we're not so good at doing that. We expect patients to know what to do, and many times people don't really sit down with patients to teach them how to use their medications and things like that. So, like I said, the asthma control test is an excellent way to start. We can look at the results of the asthma control test and go over some of the symptoms the patient's been having, and talk about that, more specifically, when are your symptoms, things like that. Have the patient set self-management goals. So I ask my patient, what do you want to improve? What do you want to see as different in your life in terms of your asthma? And patients are very good at this. Patients will often say things like, all I want to do is sleep through the night, or all I want to do is walk up the stairs without having to stop 3 times because I'm so out of breath. So a simple, concrete goal is excellent. Sleeping through the night may seem like a simple goal, but it can be life-changing for patients. Imagine waking up every few hours, every single night, because you're coughing and wheezing and needing to use your inhaler. So it can make a huge difference in patients' lives. You're going to review the asthma action plan. You're going to review the patient medication. And again, you're going to make sure the patient can verbalize when, why, how to use each of their medications. I have patients bring all of their devices and medications to me so that we can go through how to use them. And lots of times you'll see patients are not using them effectively. You're going to have the patient demonstrate the proper use of their meds. We just talked about that. You're going to help them troubleshoot their inhalers. So lots of times patients are using medications and complaining that, well, this isn't working for me, and you'll look at their medications and realize there's nothing left, the inhaler's empty, or the patient has, the medication's expired, or the medication is clogged up. So you really need to spend some time with the inhalers and get to know them and figure out, what are some of the problems that can go wrong with this. And certainly I can help people with that individually because it can be hard to know if you've never worked with some of these inhalers. We need to have patients identify their triggers. We're going to make referrals as necessary. So Healthy Homes, which is a program in Boston, but lots of other towns have programs through their public health department where they can come out and help patients to identify triggers in their home. QuitWorks is an excellent program which will help our patients hopefully to stop smoking. And again, lots of our asthma patients smoke, so this is one of the best things that they can do is to stop smoking. And I've had so many patients ask me, do you think smoking really is making my asthma worse? And they honestly don't think that the smoking has anything to do with their asthma. So we want to assess smoking at every visit, just as we do for every patient, and we want to offer support around smoking cessation for all of our patients. It will make a huge difference. We want to collaborate with the provider to refer the patient for spirometry, for allergy testing, for pulmonology as needed. Lots of these patients are going to need specialty care. And we're going to formulate a patient plan, including follow-up. So when I do patient teaching, I don't do this all in one visit. When the patient is first diagnosed, I have them get their medications and their spacers or whatever else they're being prescribed, and I have them bring them to the clinic. And we start by going over some of the basics. I show them the picture of the airway that was in the presentation earlier. And I show them the difference between the asthmatic airway and the non-asthmatic airway, talk about that underlying inflammation, and then we get through some of the issues with the medications. And then I may bring them back in a week or two to assess how they're doing, and then to get more in depth with the education. We can talk about trigger management and environmental controls and things like that. And then also at that first visit, we're doing the asthma action plan. So we're making sure the patient has the plan in place. So that's the main thing, is that this patient teaching really needs to occur over several different visits. We're not trying to, include all of this at one visit. In terms of the patient medications, we have two types. We have the relievers and the controllers. So the quick relievers are our albuterols. And these treat symptoms. They work fast within just a few minutes, and we take them every 4 to 6 hours as needed. We tell our patients that if they're taking their albuterol more than every 4 hours, that's when they need to seek medical care. It's not because the albuterol in and of itself is going to be dangerous taken more than every 4 hours. It's because we are concerned if they need to use their albuterol every 4 hours that their asthma is getting out of control. And so patients need to know this specifically. Our controllers are anti-inflammatories. So they might take something like a Flovent or a Pulmicort. They may take other things too, like a Singular for a nighttime cough. They may take an allergy medicine like a Zyrtec or a Claritin, so you really need to look at the whole picture. These controllers are going to work long term. Our anti-inflammatory medications are going to decrease some of that airway inflammation. Hopefully it's going to prevent attacks, and we're going to stress that the patients need to use them daily, even when there are no symptoms. And the Flovent's going to take, well, not just Flovent, but these anti-inflammatory inhalers are going to take several days to take effect. So we want our patients to realize that they're not going to take them and then expect that 5 minutes later they're going to get a good effect from that. So again, these patients need excellent education. They really need to understand the difference between their controllers and their quick relievers. They need to understand that their quick reliever should be with them at all times in case they have symptoms, and that they can leave their controllers at home because they're only taking those once or twice a day. So when patients come and they're in the clinic for a visit and they tell you something like, oh, I carry my controller with me at all times in case I have an emergency, then you are understanding that they need some more education in terms of what's going on with their asthma. They should be carrying their quick reliever with them at all times. Their controller is only taken on a schedule once or twice a day. Okay, so it's really important to assess whether or not patients understand that, because in an emergency or when patients are getting worse, oftentimes what they'll do is they'll increase the use of their controller. So they're taking their controller as if it were albuterol. So maybe they're taking their albuterol every 4 hours and they're taking their controller every 4 hours. So red flags. So these are things that we're very concerned about. So maybe you get a request for an albuterol refill that comes across your desk, and you know this patient just filled it 2 weeks ago. We're going to reach out to that patient and figure out what's going on. We're also concerned about our infrequent controller refills. So our patient who is filling their albuterol but not filling their long-term control medications. We're concerned about any ER visit or frequent clinic visits for exacerbations. We're concerned about our patients who miss appointments for follow-up teaching. These can be scheduled, by the way, as nurse visits. We want to make sure that our patients are coming in for their regular scheduled appointments to get education. And we're also concerned about when a patient loses their insurance. These medications are extremely expensive, and we know they're not going to be able to stay with their medication regimen if they lose their insurance. So asthma is a chronic disease, and we should treat it more like we treat diabetes. Everybody sort of gets that diabetes is a chronic disease, but because of the episodic nature of asthma, I think society's perception is that it's an episodic illness. But we need to have our patients understand that it's chronic and that it's with them even when they don't have symptoms. Our patients are going to need ongoing support and education in order to adhere to their plan. They're going to require both medical and environmental interventions. And again, your local health department is a great place to reach out in terms of environmental interventions. The Boston Public Health Commission is excellent if patients live in Boston. They have several programs there where they'll send health educators out to the patient's home free of charge, and do some in-home education as well as some trigger management and identification with the patient. Medication schedules should be simplified and costs should be considered. So this is going to be super important. When you're looking at the use of inhalers, for instance, you want to make sure that you're getting the most out of that inhaler that you can. So if a doctor writes for, or a nurse practitioner writes for a script that says, maybe it's Flovent and it's the 220 or the 110 dose, and it says take 2 puffs in the morning and take 2 puffs at night. You want to look at the cost, because it may be cheaper for them to go up to the 220 and take 1 puff in the morning and 1 puff at night. It's less puffs, it's less money. So it's going to be easier and more simple for the patient. Patients should be encouraged to identify a family member or a close friend who can offer long-term support. And lots of patients will tell me this when I say to them, is there somebody that can that you can sort of bring in and we can do education with them as support? Is that something that's going to be very helpful for you? And many patients really like to do that because then they know that somebody else is on board with them and can really help them when they're sort of maybe forgetting to take their medication or not being as vigilant as they should, or if they're getting ill, that family member can encourage them to go to seek advice from their doctor or come to the clinic, whatever it is they need to do. So I really like these couple of quotes here because they talk specifically about education. So educational efforts should be continuous because it may take up to 6 months for the effect of education to be evident. So again, we want to be bringing these patients in at multiple intervals, and I tell patients I want to see you when you're healthy as well as when you're sick. So get patients into the habit of coming to see their nurse or talking to their nurse on the phone and getting that support as they need it. I just had a patient on Saturday who was very sick with asthma, had been sick for many days, and she said to me, I said, I really want you to come in sooner next time. And she said, well, I just didn't really want to bother anybody. So patients have that idea oftentimes that they're a bother, that there's no need for them to go to the clinic. So we want to be welcoming, and we're telling our patients we want to see you before it gets to the point where you're so bad that you need to go to the hospital. The second part of that quote, furthermore, it's necessary to review periodically the information and skills covered previously because patient self-management behavior is likely to decline over time. So we know this about many behavioral things with patients is that, even a diet, people do really well in that first week and then over time they sort of slack off. So we, again, more evidence to sort of bring that patient in and to offer support over time. So we want to make sure that the patient has some point person at the clinic, their care manager, their nurse, that they feel comfortable talking to. And once a patient meets a nurse and has a name to a face, they're much more likely to then seek out that person as sort of their nurse. And this is the person that I go to when I have a problem. One other thing I wanted to talk about before the presentation ends is the use of spacers or chambers with inhalers. So again, many patients, especially pediatric patients, have been using spacers with mask or spacers with mouthpiece to take their inhalers. But many adult patients should be offered a spacer as well. So it's up to the nurse to assess the patient's ability to effectively use the inhaler with and without a spacer to determine whether or not that patient will need one. All patients with an inhaled corticosteroid should have a spacer. So if they have, for instance, a flow vent, they should have a spacer to go with that because we know the spacer will decrease the chance that the patient will have side effects. So it will hopefully decrease that sore throat that patients often complain about and decrease the raspiness in their voice. And if the side effects are minimal or non-existent, then the patient is much more likely to continue their medication. Once the patient has side effects, we know that they're going to stop taking their controller. So we're trying to make it as comfortable for the patient as possible. And the really important part about spacers is that we know that much more medication gets delivered to the lungs, to the airways, and that's where we want the medication to go. Without the spacer, the medication, most of it is deposited in the mouth. And one spacer can be used interchangeably for all of their inhalers. So for your Flovent, for your albuterol, your ProAir, whatever it is that you're using, they should be using it with each of their medications. For patients who have a hard time really taking a good breath in, I often will use a spacer for them, even if they're an older patient. So you could use I'll use a mask. So you could use a spacer with a large mask, for instance, for an older patient or for a patient who just can't take a deep breath in, either with the spacer or without the spacer. So those are just some tips for use. So that's it. Certainly people can contact me directly if they have more questions about how to care for the asthma patient. I can be reached through the Harbor email. My email is abatch ELLER@hhsi.org. And thank you very much for your time.